So now the question is, what are the one or two things that the industry needs to do in the next 12 months so that we're not sitting here having a conversation about the potential of networking and interoperability being good, but we're having a conversation about how we went from an F to a C or a B, and we have real results that we can value in that.
You know, I think we're doing some of the things now that we need to finish in the next year, so that next year at HIMSS we're talking about a completely different environment. And I think that we're seeing pockets of greatness, right, where a whole lot of different hospital systems are talking to each other in Ohio, for instance. There's lots of places around the country, and there's a lot of vendors like you guys and others who are allowing interoperability to take place. I don't know if we're going to talk about meaningful use at all. I think it's really important that people realize that the extension of stage 2 meaningful use was a delay in the beginning of stage 3. It has no impact on what you need to do in 2014 yet. And my hope is that they're going to allow some flexibility this year for stage 2 meaningful use too, because otherwise we could wind up with a sort of digital divide, right? And I know that there's others that would say, hold their feet to the fire and make them do it. And that's fine for the health systems and the large organizations that have the wherewithal to do that. But as I go around in rural communities, critical access hospitals, small physician clinics that don't have the resources to do this, I think the people that we need to hold their feet to the fire are not necessarily those rural providers and critical access hospitals in underserved areas where they're struggling, but the people that are here in this exhibit hall and the vendors. They're the ones whose feet need to be held to the fire.
So I'm torn. I think there's a communications problem still. I mean, there are too many different ways of exchanging data, and no one quite understands which ones are going to be the dominant ones. And I certainly am a little bit concerned that, and you know, you guys will correct me and David will correct me, that direct is going to be between doctor to doctor and not really get the patient involved in a way that's easy for the patient and the consumer to be involved. Because to me, the really big gap, you know, I've looked at healthcare systems across the world for a long time. Everybody has a big gap between the patient and the primary care doc, and between the primary care doc and secondary or tertiary care. Those gaps are still there, and they're going to take a while to fix. If you can at least get the patient and their caregiver as much data as possible, then we've got a hope of actually doing some good more quickly. So that's why I'm optimistic about Blue Button.
You know, I think that's the next wave to occur. Let's make sure we nail this as far as provider to provider and being able to have the right information in the right place for the right caregiver. But I agree with you completely. You know, in terms of access, I think that, you know, we've got with the HIPAA omnibus rule really expanding or clarifying the patient's right to access their own data. And the technology is not the hard part here. And I think as we see more and more alternative payment models coming into play, where having an engaged and empowered patient is going to be key to the success of the healthcare organizations, we're going to see more of that occur.
So I think there's maybe two buckets in which to answer that question. I think the first one is the idea of make the right thing to do the simple thing to do. So the number one thing would be to get messaging in front of the doctors in the middle of their workflow, period. If it isn't there, it ain't going to happen. If incoming messages aren't visible to a clinician in a way that they want to see them, and if there isn't a way for them to initiate communication the way they want to, it isn't going to happen. So that falls fundamentally to the vendors of EHR systems and those who serve them, which is the networks that connect directly to them. But if it doesn't happen in the systems that are being provided by the vendors for meaningful use, stage 2, we're not going to see the takeoff we expect. Now, I'm optimistic about it. We run on both GE Centricity Enterprise and Cerner, and it looks like there's reasonable methods in which that will be embedded within the clinician workflow. When a patient wants to come to a place like Mayo Clinic, and we get patients from 150 countries in all 50 states every year, it needs to be incredibly easy, to get back to the comments made earlier, that a primary care physician needs to be able to send a referral to Mayo. We need to receive that patient with full fidelity. We need to treat them and return the record back to their location of care. So I think it's actually pretty simple. Get the EHR vendors to do it right, focus on direct, figure out how that evolves over time, and away we go. I would observe that I think the species Homo medicus is an elusive and slowly evolving species. And we'll see what happens over time as it becomes easier and easier for them. But I think a lot of times people are going to say, I don't want to manage my medical records. I want someone else to do it for me. And when something bad happens to me, then I really want it to be in place. And that's what we all need to, I think, be putting in place as a precursor.